Hello, everyone. This is Scott King with Becker's Healthcare. Thank you for joining us for today's webinar, How Allina Health is Building the Operating System for AI Transformation and Driving $7.3 million in Added Annual Surgical Contribution Margin. Before we begin, I'll walk us through a few quick housekeeping instructions. We'll begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. If at any time you have issues with audio or visuals, just try refreshing your browser. You can also submit any technical questions into the Q&A box. We're here to help. With that, I'm pleased to introduce today's speakers. Bill Evans, Senior Vice President, Chief Medical Group Operations Officer at Allina Health. Donna Sajady, Business Operations Manager, Surgical and Perioperative Services at Allina Health. David Atashru, MD, Chief Clinical and AI Officer at Qventus. Thank you, Bill, Donna, and Dr. Atashru for being here today. And I'll turn the floor over to you to get us started.
All right, thank you. All right, to kick us off, thanks for everyone joining. We have a real privilege today to hear from the team at Allina and some of the work that they've been doing in transformation in hospital operations at their health system. We'll start at giving a little bit of a background on surgical services and where they began their journey. And then from there, how they expanded into an enterprise strategy with Qventus, inclusive of building and co-developing solutions together in our AI solution factory. Donna and Bill are really open, very knowledgeable. They're very willing to share with you their experience and what it takes and what they've learned along the way. So please be open with questions. We'll try and get to as many of them as we can as we go through. So with that, I want to spend just a brief minute introducing you to Qventus. And I think first and foremost, just to ground us, I'll ground us clinically. I'm a surgeon, so let me start with the uncomfortable confession about American healthcare that I've seen. What I would say is that we have some of the best therapies, clinicians, and equipment in the world, and yet getting quality care in this country can still feel like pushing a rock up a hill. In every health system I've worked in, the math is the same. From cut to close, as a doc, I control the outcome, and that's maybe only 40% of what the patient experiences. The other 60% lives in the operations around the care, which is what I call care operations. It's the missed referral, the surgical cancellation, the underutilized OR, the inpatient excess days. It's invisible when it works, but it's expensive everywhere it doesn't. And I can't control any of it from the operating room, yet it moves quality and experience and margin as much as my hands do. So every hospital that I've seen compensates the same way. We ask our staff and honestly our patients to do extraordinary things to get ordinary things done. And we do that every single day. We put a shadow workforce behind every clinician, navigator, scheduler, coordinator, and task them with gluing it all together. And half that work is below the top of their license. And we're stuck because generic tools can't do this work. It takes clinical judgment. And that's the premise Qventus exists to solve. We build AI teammates, we call operational assistants, with clinical judgment built in. They don't flag the work or dashboards that do the work. They actually do the work themselves. They chart mine, the scheduling, the chasing, the documentation. So the shadow workforce gets to practice at the top of the license, and the 60% starts to work as kind of as hard as the 40. And what you'll see today is what that looks like when a system commits to it at enterprise scale. And nobody in the country has gone and done that farther than Allina. And for the last 10 years, we've partnered with them, and we've been partnering with others to be a leading AI platform to deliver the ROI for the hospitals that secures the margins to support their missions. We've done that across the spectrum from academics to community hospitals and safety net institutions. And honestly, this is their work that we get to represent, and we're really proud of what these health systems have accomplished together with us. That's the ROI that they've achieved, but it's also how quickly they've done it and the benefit it's shown to patients. So with that, I'll turn it over to you, Bill, share a little bit about the Allina Health System.
Absolutely. For those not familiar with Allina Health, we're a large not-for-profit health system serving the Minneapolis-St. Paul markets, really about 2 hours surrounding the Twin Cities market. Starting at the top left, just a few items for awareness. We have about 28,000 really vital care team members, about 82,000 surgical procedures, and then about 6 million clinic visits And then in the end, it's really driven by about 6,700 providers who are either employed or affiliated with the system. So a lot more information on the slide, but of course, just want to make sure you had a few of the key highlights for today.
Awesome. Thanks, Bill. So with that, I'm going to switch gears. And Donna, I'll turn it over to you to talk about Allina's experience in surgical services.
Sure, thank you. Donna Sajady, I'm part of Abbott Northwestern, which is the flagship largest hospital within the Allina healthcare system. And going through this exercise was really reflective to going back to where we were in 2022, which feels like a very long time ago, but really truly only 4 short years ago, where we were challenged with block utilization, subutilization, and yet a demand for access and a need for access. So a real disconnect there. As well as at that time, most vocal were our robotic providers, where continuing clamoring that they could not get access to the robots, but our utilization didn't match that same sentiment. So we knew we had a disconnect just with those 2 applications with our scheduling process and resources and what we were actually seeing and feeling from utilization and process. So we decided to target this new technology with a very specific block management and robotic availability. And if this were successful, what else could we do with this? So it was a very microcosm of our what now is an entire process. Utilizing the system for on-block time. We have processes for releasing block time, but Cuventus allowed us a systematic standard method of block releasing and block management. The system ability to nudge offices when unexpected use of time is there to ask them, prompt them if they need to release. We also, overall, Allina is about a 25% independent providers. At Abbott, we were closer to 40% at that time. So we had very unique processes with our independent providers and offices and our Allina providers and offices. So we knew we needed a system that could work within both of these 2 schemes, independent and our Allina provider groups. It was clear we had challenges. What we had developed internally was not addressing it. Trying to create a safe scheduling to electronic and doing that in-house, we weren't really accomplishing what we needed. So we searched and looked and decided to take a look at Cuventus.
Awesome.
Our experience quite rapidly found an increase in availability for additional cases. We were seeing an additional 3.5 cases per OR. Abbott Northwestern, that's 35 ORs. So we saw also a robotic program growth of 36%, spine cases 18%, and offices quickly adapted to the system and process. So really, those targeted functions of blocks, robots, identified that this really was a strategy and a solution that could work with our challenges.
Donna, that's great. I really appreciate you sharing some of those results. I do want to ask, oftentimes with these technology implementations, there are growing pains and stumbling blocks that are encountered along the way, and it can feel like a marathon to get any meaningful results. What do you attribute the early success to?
I would say it was the technology, and it was a technology that we could adopt and adapt based to our provider groups. It needed to be ease of use. We also recognized that partnering with some surgeon champions to implement and gain that support and traction, which was primarily with end users of using the system. Also aware that those office schedulers own a lot of power into where cases are performed. They needed an easy, least resistance in being able to schedule cases, and hearing the experience of where some of our independents were challenged, knew that we needed to market to those challenges with a system that would make that resistance go away. Cubentis, honestly, working with targeted training, both in-house with our Allina provider groups, our independent groups, rolling this out with a phased approach with our block owners, and then our robotic surgeons, and then Allina, and then independents. But once we started those microcosms, it broadcast really quickly that we almost had to hold them back from a more rapid fire. They were anxious to implement and use the system far more broadly. But it really was the support with Cubentis in adapting these tools and training, which really made us successful.
Yeah, that's super helpful. Maybe say a little bit about kind of how the adoption went. I know that we had like initial plans with you all and a kind of a staged rollout. How did that go compared to plan?
It was a matter of holding back some of these groups once they heard, seen, and experienced. I want to say both from those who own this process, being our office schedulers and our surgery schedulers, and quickly adopted by both, and all were eager to say, how can we do more? How can we get this out there more? We want to move cases faster, right? So it was adopted much quicker than we expected, for sure.
Yeah, that's great. I think at the core, what our surgical services solution did was balance supply with demand in the operating room. And for us, it was about ensuring unused time is available for other surgeons and filling that time, not with just any case, but what actually met your strategic objectives, making that programmatic, that when you set those strategies, they just get baked in to the day-to-day operations. So Donna, what I think I may do is take this minute to kind of share a little bit. Everyone always asks to see the product and do a little demo. We'll do a little bit on this call for the people on the webinar. It's not possible for us to go to the full depth. And so if it piques your interest, you have questions, please, let's set some time later. But I want to share with you a little bit about how we do these things uniquely. Because I think doing the easy thing, like incentivizing block release, feels easy. And sure, if you want to get a surgeon to release their time when I'm on vacation or if I'm going to a conference, that's super easy. But when 50% of your opportunity lies in partial blocks and you're asking me to do something that I don't want to do, that's hard. And so we'll talk to you about how we do this in a unique way. And I'll actually start with block release with the personalized and compelling nudges and show you that. So in that regard, let me pull that up and show you. We call this actually the capacity assistant. And you get a chance to see under the hood a little bit about how the modeling works to make that possible. And so you're seeing here us actually doing the underlying thinking, where an hourly ML block prediction is looking at each individual block and predicting, let me go back there. I'll do that again. As we get that going, you're going back here and seeing how the model is actually thinking underneath. It's not about saying just as their time, but I've got to identify the block that will go partially unused. I've then got to look at the 0 block in OR6 from 11:25 to 5 p.m. Then I got to figure out what contiguous portion of this time the surgeon actually is not likely to use. Then I've got to look at their booking patterns, the number of days left, figure out what confidence level I need to have, and then actually only predict the component of that time that actually we think that's going to release. Then I need to actually calculate the incentive for the doc and then pull it all together to actually draft the message that goes out to the surgeon. You can see that it's much more than just a rules-based system. It's an intelligent system that personalizes the ask to what's specifically happening for the provider. And then that gets created in an outreach that looks like this to the physician. Donna, can you speak to this really quickly about, and I'll pull this up in a different format so that we can see it. Can you speak to this really quickly?
The block release, it was something that we needed to adapt and adopt to, because there was the system accumulates that history and anticipates surgeons using or not using time. So our oncology providers are scheduling in a much shorter period of time. So it is not nudging them at the 3-week mark that they haven't released their block, because typically they are not scheduled within that time. Our total joint surgeons who do schedule far further in advance, the system will nudge them at our required 21 days just to verifying that they're going to use their block time. The other thing we've leveraged this with is on our block review process, and those with subutilization, being able to provide data to the surgeons that says this block was unused, it was unreleased. We reminder nudge to yourself or your scheduler on X date, and it was ignored, it was accepted or denied, and denied assuming that they're fully going to use that time and did not. So we can give them very specific process information on their releasing or lack of releasing process, and it has brought that into much more better accordance.
Yeah.
With our spine and orthopedic providers. Go ahead.
No, go ahead. Sorry about that.
We're still exceeding and improving our overall block utilization, which was probably in the mid 60%, now to 72 to 78%, which is pretty impressive. 30 to 40% of our rooms having swing, and our release rates. Monitoring what is our percentage release rate, those peak vacation times we expected, or also addressing, do we have too much block time allocated to providers, and to address that and maybe right size blocks. All that information's been readily available in Qventus.
Yeah, that's really helpful. I think the other challenge is when you have that time available, thinking about how do you end up filling that time. And as a clinician, I think the thing that really stood out to me as I partnered with Donna and Bill was that really we don't want it to be like an open table. Not everything is equivalently important at a certain period of time. And so we actually want to recruit the volume that is most important to get the right case in the right room at the right time. But how do you do that? If the schedule is just fully open and anyone can book anywhere, how do you actually shape that demand so that actually happens? And the other challenge that you have is you can't do that in a very generic approach. If you generically reach out to surgeons' offices with blast emails about available time, and only 2 out of the 20 times are relevant to them, you're actually creating a negative reinforcement loop where the scheduler in my office thinks, this is noise. Because if she looks at the first time and is like, I never operate that day, and the second time doesn't have my equipment, and the third time that would never work for our cases, all of a sudden they learn to tune out. And so we flip the script on how that happens using what we call our strategic marketing assistant. I'll get a chance to show you that now. And what that does is it ingests your priorities as an organization and then uses that as well as the likelihood that the surgeon is going to want to use that time to create a score for every surgeon against every available time, so that we're reaching out in a prioritized manner. And you'll see a little bit about how that works behind the scenes. So in this case, there was the strategic marketing assistant found this gap in the schedule in OR5. And the first thing it's doing is applying a set of hard filters. And it's saying, these set of surgeons never operate on this day, don't operate in these places, aren't credentialed. And then what it's doing, and you can see the surgeon's rank changing, then it applies priority levels. Is the surgeon available? What's their likelihood to use that time? What is their past booking behavior had? What are their preferences? This is an optimization ML model that's actually running specific to this. What are their room and equipment preferences? And look at Max. His rank is steadily going up. Where he started at the bottom, it's coming up to the top. Now we're pulling in the system priorities. What are they trying to grow in targeted volume? What are the site of care priorities that they have? What are their splitter surgeons? Who are they trying to harden referral patterns for it? All of that is the reason why Max went from the bottom of the stack to the top of the stack for that specific available time. And you can see what that looks like here as well. And I'll navigate to that right now. But Donna, talk to me a little bit about this and what this has meant for your team, being able to have these personalized times brought to them that are unique for each of them.
Right. I know at a system level, there were some targeted service growth places. And so we could align that with Qventus on particular service lines that we were trying to target our growth in. And so they were at the top of the list on that availability nudges. And it is true that it is only marketing available time to a surgeon's actual schedule pattern. If he is in clinic on Wednesday, it's never going to let them know that there's Wednesday time open. So it's very surgeon specific, not a generic or general broadcast, but very targeted. And within that, we could target those nudges to specific service lines or growth focused areas.
Yeah. Yeah. I think the other component of this is, as much as you really want to be able to create this magic and a learning system that knows when to send time to individual clinics' offices based off of their preferences and patterns, you also want to make it so that when they're looking for available time, it's just as easy to find available open time as it is block time. And that changes their default practice pattern to say, I'm not going to just book out 6 weeks into my next available block. I'm going to actually consider the next available open time. But to do that, you have to make it so that any clinic can find time in 10 seconds and fully book it in 2 minutes, and specifically inside of their workflow. And I think one of the challenges that we had with Allina is that they have a large affiliated provider network. And the reality is those providers, the clinical providers, their default system is not the health system's EHR. It's actually the EHR that is their clinical EHR that they do work in every single day. That's eClinicalWorks, that's NextGen, that's Athena, that's Greenway. And so we had to go do the work to embed inside of those EHRs so that the health system can have a competitive advantage in where those affiliated providers take their cases. Because now, instead of having to go into a different system and then double document their cases, they can stay directly inside. In this case, this is an example of Athena, inside of their system, and then book the case directly into Allina. And I'll show you a little bit about what that looks like. And so here they can one-click launch Qventus inside of their clinical EHR. They can see all the available time for this specific procedure they're trying to book. They can add any notes for the scheduler that are important. And look at this. Instead of having to go double document all of the information that's already in their clinical EHR, it auto-populates. These are fields, 10 to 20 fields that they would otherwise have to do, that they would do in an error-prone way that costs them an additional 5 to 7 minutes per case to get it booked when they do the traditional path, having to go through the hospital's EHR. But because they're able to stay in their own EHR, they can just document by exception. They can add all the documents that are relevant. In this case, the H&Ps, the orders, the consent forms get uploaded. We use an OCR technology to be able to write that back into the Allina's system so they don't have to do the work to do that themselves manually. And also, we are able to write this request directly back into the health system so it lands in the depot without asking the OR schedulers to have to do extra work. Really cool example of creating a unique way to align affiliated provider groups. The same system exists as well for the employed physicians, where they can one-click launch Qventus inside of their EHR, so they don't have to go elsewhere, and they're already logged in through SSO. They're able to, in this case, select their surgeon. I'll select Lewis Hamilton here as an example, select their patient name, select the time that they're looking for this procedure. Select a procedure. This auto-populates with your own procedural directory. Notice that there is actually an ML model behind the scenes that is more accurate than what you would natively get in your EHR for predicting case duration. It automatically populates what you see in here in green, the block times, and then in blue, the preferenced and prioritized open times. It's customized to that individual provider, that individual case, in the strategy that you're trying to drive, pulling the cases, the times to the top that the surgeon's most likely going to want to use and that are most important for them to select. They're able then to select those times, and if you know about how schedulers operate in the clinic, they always follow the path of least resistance. So we pull the times to the top that are the ones that we actually want them to use and see, and then again, make it really easy for them to submit that case request. Donna, would love your thoughts and just share a little bit about what this has meant for Allina, this process of being able to book time more easily when they're looking for it.
Absolutely. Them having real-time access to availability and submit their cases 24 hours a day, 7 days a week, not within the constraints of a scheduling office open and availability. We now have office schedulers who are living all over the country supporting their providers here. There is no constraints for time. We have a unique process for the Allina EMR requests. They still have line of sight to the schedule with minimal booking requirements. And then those who are independents who may be attaching their clinic booking sheet or completing that form. So all of which very easy for the offices for submitting their cases. I love to tell the offices and training new ones or those onboarding is, you know, I'm old enough to remember when we had travel agents, and if I wanted to fly, I had to call a travel agent to book a flight. I can now in my recliner, anytime I want, look for pricing, how many stops, do I want direct? Very same thing, very similar process with scheduling OR time, and not required to call the scheduling office at a set hours and potentially waiting on hold. So it's been very well adopted by clinics.
Yeah, I see the same thing in clinics that we work with. And when given the choice, I think teams will always default to what is easiest. And by making this and the more natural path, maybe Donna, just speak to how adoption went. I know like we really thought through, should we mandate this? Should we just see it, how it plays out organically? Maybe share a little bit how that went.
Yeah, we did not mandate it. That wasn't the approach we took, and we didn't need to. People quickly adopted and wanted it. And recognize that Abbott went first by a couple of years to the rest of the line of providers. And we have hospitals. And we have many clinics that go across the various hospitals, and they were eager and anxious and asking, when will we be putting this at Mercy or United or even the community hospitals? So yeah, it wasn't enough that, you know, Abbott was using it and they liked it. When can we use it everywhere? So adoption there. You know, another side benefit that we did not expect was the waitlist functionality, David, where find cases, complex cases, and those are heavily blocked rooms that on their side, completely independent of the OR, they could set a wait list for a particular day, date, time. And as soon as a case either canceled, a block released, a block auto release, they were notified that that time was open. They didn't have to keep calling scheduling. Is it open? Is it open? They were actually alerted there is time on this date at Abbott Northwestern, and they immediately could submit those requests and get that time.
Yeah, and I can
a huge benefit for clinics. Yeah.
Yeah, and I can see that's pretty well conserved, Donna, across our client base. I think as a provider, I've seen this happen before as well. It's just that I know I have a case and the time just isn't available. I want to let you know about that, but I'm also not just broadly available at any time. So it's important for me to be able to specify, look, like I'd like to wait list for this specific day or these AM or PM time, because that's when I actually have flexibility. Knowing about time that I can't possibly use isn't super helpful. And so I think that nuanced ability to do that and provide that notification ahead of time to the OR so they're aware, and then make it easy for me to then book is something that's been a big win for provider offices. Last thing, and then we got to transition. I want to spend the back half talking about how the partnership has expanded. Let's talk about robotics. I know that some of the opportunity that we had with Allina was you were a premier robotics account and really invested in utilizing these assets well. And we partnered with you and Intuitive to make sure that we could advance your strategic goals for using robotics. And there's a bunch of bespoke models that we built to enable that opportunity of moving those non-robotic cases out of robot rooms, and then also analytics and governance that we helped create to be able to make that more possible for you all. But maybe Donna, could you just speak really quickly to what your experience is collaborating together on robotics?
Yeah, absolutely. A number of things we've implemented with Qventus that has assisted us with optimizing robotics. One of which is that nudge, an alert, if we have a non-robot case in a robot room, whether intentionally or accidentally, that we're reviewing, confirming, and approving those times, those cases being in those robotic rooms. Secondly, our robotics council, we meet monthly just to manage this really limited resource. the highly coveted robot block times that have been allocated, how well are they managed and measured. But the amount of time for generating that data for the Robotics Council meeting was, 4 to 6 in preparing the slide decks and getting the specific division available is now like under a 10-minute process. And having far more specific data, not only overall robotic utilization by room, by day of week. We've been able to target new block owners to specific days where we could see subutilization and opportunities. And it was hard, fast data available and not just a sense from scheduling.
Yeah.
So it's both time and effort in reporting. Yep.
I'm really glad that we were able to partner with that one. That felt like a really big win, just to be able to make it easier for the team to do the things that they know they wanted to do and manage that robotics asset like a program versus just like an asset on paper. I know we have to move with time. So Donna, going back to you, these are the results from 2025, 7.3 million in contribution margin, nearly 700 hours of additional robot capacity and a 6x return on the investment. Talk to me about the difference between when you first started in 2022 and the continued results you're seeing now.
I think I shared in the beginning, there was a reluctancy, and we will try this on blocks and we will try this robotics and we'll see how it goes. And it went well. And we quickly saw the benefits. And we also just find issues. First leverage is usually where can Cuventus help us with this? Also seamlessly, as we're building a whole new surgery tower, we're moving in 5 weeks. Simultaneous scheduling rules for our existing 35 ORs and moving to 38 ORs with all different rules, guidelines, and keeping that seamless for the offices has been paramount. That manual intervention would have been a real challenge, but it was seamless whether they were scheduling a case for September 8th or August 8th. They were completely different rules, different blocks, different guidelines, and it's gone seamlessly, which speaks highly to the system and the ability to use it.
That's awesome. Thank you, Donna, for sharing that. What I'd like to do now for the back half of our time is just shift gears and talk a little bit about what came next after the work we did together in surgery. So Bill, I'll actually turn it over to you. Donna shared some of the great results on the surgical side. Talk to me a little bit about what those results meant for Allina and what we're working on now to expand.
Yeah, absolutely. Well, and congratulations to Donna and the team. To be able to see this really come to life across the enterprise is just incredibly powerful. To be able to have a surgeon anywhere in the enterprise trying to visualize and schedule a surgery and as seamless and easy as that is really quite impressive now. So, from there, we really felt, I think, very proud of what we developed and how that has all come together in partnership with the Cuventus team. So, that foundation, I think, was really key for us. What we heard in that implementation from our IT partners, for example, was that Cuventus really was the best-in-class partner that we'd worked with. And so that, I think, really set the foundation for a strong partnership. Obviously, the Cuventus platforms continue to grow and evolve. And, with that, there's a lot of changes going on in the industry and the technology. So, with that, as we think about it, we certainly think the surgical piece is vital. Surgery is obviously a key financial and care piece for any system. So that was obviously where we really wanted to start. From there, though, that product and solution really has continued to grow and evolve. As Donna was talking about, it's really become a powerful tool over the past several years. At the same time, Cuventus really has been developing and growing its entire platform across a couple different areas. And so building on the confidence that we had from that first initial work in the surgical area, really, I think, enabled a stronger partnership in some other areas. And then, as I mentioned, just AI in general really is advancing at a speed that is quite staggering. And so that combination, I think, really gave us some excitement to see where we could go as well.
expanding on our platform, I think one of the things I would say is we put a lot of focus on building a platform that is both flexible and nimble. And that can be applied to a multiplicity of different use cases. To think about that for the people in the audience, actually to do that, it starts with a core set of capabilities and data integrations that you see at the bottom. What is important here is that we can pull data from pretty much any source, and we do, both structured or unstructured, and then we act on that data. What differentiates us and our AI operational assistants is that these agents were built with a myriad of skills that you can see here. They can chart mine, they can do a continuous risk determination, they can do coding, they can do documentation, they can manage documents. They have the ability to do multimodal communication with patients through text and voice and fax, what we call patient concierge, and they can do scheduling and intake. These skills then are built to be applicable to a lot of different areas, and they're extensible. And that lets us build out of our 4 core solutions in periop and surgery and inpatient and care gap and coding automation, and now in specialty referrals in the ambulatory space and in call centers. Those solutions span kind of the ambulatory space all the way out through discharge. And those skills will let us co-develop with our partners, which is the part that I want to touch on here in a minute. This slide shows Allina's expansion journey. It's anchored by the surgical growth results we discussed earlier. But in 2025, Allina expanded into the perioperative care coordination and inpatient capacity space. And so I want to touch on those spaces just briefly and give you an overview of what they do. So first off, PCC. Here's the problem that PCC solves today. The moment a surgery gets scheduled, the clock starts. Somewhere in the patient chart or in an outside record or buried in a note, there's usually a reason that a case could fall apart. It's an anticoagulation that was flagged. It's a cardiology clearance that never arrived. Today, that finding is manual. It's dependent upon people. Nurses play phone tag, they chase faxes, and too often the surprise shows up the morning of a surgery and my team has to cancel a case. PCC, this solution, puts AI on that clock. It reads the entire chart, including the outside records, including everything in Care Everywhere, and including everything in the media tab, and the narrative note, structured, unstructured data, against more than 200 surgery and anesthesia-specific conditions that we developed by clinicians, like anesthesiologists on my team, reassessing risk continuously until the day of surgery. And then it reaches out to patients by text, in voice, at all hours of the night, in their own language, and drafts the documentation as well, through email and into the record as well inside the EHR. So nurses actually stop being the record chasers, and they actually get to be clinicians. And the differentiator is that it doesn't flag work for your team. It's not just documenting where the work is done. We definitely do that. It actually does the work and catches what the humans miss. And so, Bill, I'd love for you to talk to me a little bit about why you decided to expand into that perioperative care coordination solution.
Yeah, I appreciate it. Certainly the benefit that we saw coming out of just the surgical solution gave us the confidence to continue to expand. We saw the PCC really as the next natural evolution, as you say, trying to really use all of our operating rooms and our staff to this highest level is really a key area. So we know that any late case cancellation is, it's a surgeon frustration, it's a patient frustration, it creates a delay in care, and obviously it's waste in our ORs. And so we really saw this as a very natural extension of what we'd already built.
Yeah, I'm excited to see the outcomes and the data from that soon. And that was pretty exciting work that we've been doing together. I'd love to just kind of also move on to inpatient capacity. We went live with that at the same time. And so maybe I'll give a brief background on that, Bill, and then would love for you to share a little bit about how you were thinking about inpatient capacity as well. So inpatient capacity was actually one of our first solutions that we built. And Allina's goal here was pretty direct. It was, how do we reduce excess days and bring down length of stay? Every excess day is an infection risk for our patients. It's a worse patient experience. And it's a bed the next morning a patient boarding in the ED can't have. There's plenty of tools out there that will tell you how you're doing, how full you are. They'll give you forecasts. They'll give you command centers. They'll give you flags in the record. But a forecast never discharged anyone. The work still lands back on your nurses and your care managers. That's actually capacity management. But what we are talking about at Qventus is capacity creation. Our AI assistants embed in the workflows the teams already use. This is fully embedded into Epic and into Cerner. They set an early and an accurate discharge for every patient and show which patients are in jeopardy and actually what's holding them back. It's the CT that won't happen until Monday, or it's the case management gap on Thursday night. And then they actually act on it. They prioritize ancillary services against those discharge dates. That's actually happening embedded inside the EHR, just behind the scenes. So the imaging study or the PT eval that's gating today's discharge jumps ahead of the one that isn't getting anything, and closing the loop with nudges to the right owner and the documentation inside the system. The health system sees a 15 to 30% of excess days come out. That's the benefit to them. And 2,000 days saved at one client meant 400 more patients served. Managing capacity is knowing that you're full. And I think that's the problem. We don't want to just know that you're full and see the problem. Creating capacity is actually making the room, which is what we do with this solution. Bill, I'd love for you to tell us about a little bit more about that work that we did together here.
Yeah, absolutely. You said it really well. And this is where I think there's a big unlock as we start thinking about having a complete platform that can really help start thinking about capacity writ large. Obviously, surgical volume is a piece of that, but as you point out, really making sure that we have a plan for discharge, that we're being as efficient as possible, making sure that everything works as intended is so important. And so in this particular case, expanding from what we'd already done in the surgical growth area into the inpatient capacity, again, really trying to have a holistic approach of that patient journey through the hospital to be as efficient as possible. That's really what I think we're really excited about. And so I think this one is really, to your point, helping to make sure that patients are able to get out as fast as they want. People want to be home. They don't want to generally be in a hospital if they don't need to be. So the more that we can expedite that, I think the better for everybody.
Yeah, totally. And I think the exciting thing is that this year we also built on that and we added our newest solution, working together. And that one I'll highlight just really quickly is the care gap and coding automation solution with the initial focus on malnutrition. I think it's important for the people in the audience to just kind of have an overview of that. So our new suite starts with net malnutrition. And I'll tell you why we did that. Roughly 1 in 3 hospitalized patients today in America is malnourished. And most of it never makes it into the record. That's really like a double failure. The patient misses a nutrition intervention that changes their outcomes. And honestly, I just don't often have times to do it because it's one of 20 things on the reason why they're admitted. But then on the hospital side, the hospital delivers a real acuity of care that it never gets credited for or reimbursed for. And that's unfair because the dietitian's findings never actually become a physician documentation. So our AI closes that entire loop. It reads the chart, identifies likely malnutrition, drafts the compliant documentation for the physician sign-off, and carries it through to coding. It's teeing up the team to do the intervention and bring it forward. Detection of care to documentation to reimbursement automatically. And malnutrition is deliberately the first condition. It's not the last. We're moving into AKI and encephalopathy and all these other conditions that matter to the health system, but it's a repeatable pattern for closing care gaps across the chart. And that's why we call it a suite of tools in this care gap and coding automation. Bill, maybe just here, talk to me about what the goals are with it and what you've been solving for it with Allina.
Yeah, very similar conversation. So in this particular case, we have significant value-based care dollars with risk in there. And so this is another one where it really ties to not only the efficiency, but also the documentation. And in the end, it's all about providing better patient care. And so as we think about all of these solutions, that really is our focus through all of these things. So in this case, we want to make sure that we're actually closing care gaps. To your point, making sure that if somebody actually has a malnutrition issue, that we can identify that and solve it, and then also make sure that we document it. So we see this as a natural extension of what's going on in the inpatient capacity. And so these things all continue to build on each other. And we really do think there's a multiplier effect that comes with all of these together.
Yeah. I think last thing to talk about with the time that we have is that we're starting to see the fruits of our last partnership, which is our AI Solution Factory partnership. Remember, this is the one that we co-build solutions together. And we've picked a number of things to focus on and solve challenges related, in this case, for Allina to referral leakage. There's a huge opportunity here. And what I'd like to do is dig into this one deeper in the next section. So I'll move over to that. So in addition to expanding our other solution, Allina also became Qventus's inaugural AI Solution Factory client. And Bill, what I'd like to do here is we'll dig into what that AI Solution Factory is, why this co-development model made sense for Allina, and kind of how we were building this one together. So first thing before we dive into that, we talked a bit in the previous section about automated care operations. What I want to emphasize is that Qventus' vision for what that means. We see automated care operations as the infrastructure. It's a category that's just as important to a health system's performance as the EHR is, or your ITSM, or your revenue cycle management system. That's the level of impact that a platform like Qventus can have here. And the AI Solution Factory partnership gives the health system another way to take advantage of the capabilities we've built, in addition to the core solutions. It's a way that we've customized it to let them solve some of their biggest challenges. Bill, what do you see? Where do you see that? Where do you see automated care operations fitting in your infrastructure and strategy?
Yeah, I think this has been one of the exciting things coming out of our partnership. We do know that just in general administration within healthcare, there is a lot of hidden waste and inefficiency. And so as we think about how AI can come into these areas and really help transform some of the operations, I think it's a really exciting opportunity. So I know we'll talk a little bit more about what this is looking like in Allina, but I think just having the new technology coming in to try to solve problems that we simply could not do through manual processes, through human intervention, that's what I'm just really excited about. This is actually a career highlight for me in that way.
That's great to hear. All right, I'll give a quick background on this AI Solution Factory for the people on the line. So first off, the AI Solution Factory is Qventus' co-development partnership model to build custom AI solutions. What we did was we created this model after finding that many of the health systems wanted to leverage the latest advancements in AI, but the things that they could get out of the box either didn't address the use cases they were focused on, or they didn't work well for the existing processes for one reason or another. And since we had built this really robust platform, we started having more conversations with health systems about different ways our AI operational systems could actually be deployed. And it led to this co-development model that satisfies what the health system is looking for and allows us to continue building out the AI solutions in a way that gives our partners exactly what they need. And I'm going to explain what this model looks like, and then Bill, we can talk through what the experience was like for you at Allina. There are 3 key steps to the co-development process. One is we get really deep in the weeds of our partners' operations. Our engineers are embedded in the day-to-day operations, so we have an intimate understanding of how things are actually working. That's essential for solving this kind of complex challenge that as the AI Solution Factory solves. And then we work really closely with the health system leadership to identify areas of potential focus. This mainly comes from our partners sharing a wish list of operational challenges or gaps they'd like to close. Then we work to understand the complexity, the opportunity size, and align across the organization on what's really most pressing and what will likely yield the best results in a reasonable time frame. Then what we do is we actually build on what we decide on. Qventus takes the lead in building, and we get client feedback throughout the process. That's one of the benefits of being so embedded within the organization. There's plenty of opportunity for feedback, and the development loops can be actually really quick. This deep partnership also allows us to move quickly and effectively. So I'll pause there, out there. Would love to hear from you, Bill, but just overall, your thoughts on the model and the experience you've had so far.
Yeah, it's been remarkable. I know that we want to make some time for questions and answers, so I'll be brief with this, but this really, as I mentioned, has been a highlight for me. So, thinking about this solution, actually having engineers dedicated to actually be able to go solve real-time problems has really been just quite amazingly powerful. In this particular case, one of the things that was a highlight for me this year is we actually did an AI hackathon. So we invited team members from across the organization to submit ideas where they thought that this technology and the partnership with Qventus could actually help solve real-time problems for them. We had about 100 ideas that were submitted across the organization. Unfortunately, we only had 5 engineers that were available, so we had to limit it. But coming out of that, what we ended up doing is literally we introduced the team to the AI engineer, and within 24 hours, we had a working prototype that was actually improving patient care, improving the safety of our teams, improving the bottom line and the efficiency for the organization. Really quite amazing what can actually be done in a very short time with this technology and the partnership. So I'm excited. We've obviously just started in this, and I think as we continue to really build on this, it's going to be powerful. I think we can show the next slide has a concrete example or two in here, but the the innovation cohort has really been powerful for us. So as I mentioned, that hackathon. But then in this case, we've also been able to go deep into a couple specific issues where we think we have some opportunity. So in this case, what you're seeing on this slide are two things that we've really been focused on. We know in the organization at the size and scale that we are, that there are things that don't work quite as intended. So in this case, we thought that there might be some referrals that were intended, but never got completed for some reason. Something got hicked up in the system, something along the lines that just didn't work. And so we really had a project that came together looking for hidden referrals. In this case, in the very first day, we were able to identify a patient, contact them and get them scheduled. So it showed the power of what we were able to do instantly. And then as we now start thinking, expanding across this, across the system, across all specialties, really a big unlock. Again, these are care gaps that would have potentially existed. These were patients who were expecting follow-up care from us that we might have missed. So a really great patient experience of how we're solving this with technology. And then down at the bottom, fax referrals. I've got a stated goal. I don't want to have another human actually look at a fax in 2026. So I want the technology to take over and help solve that problem for us. So just a really couple concrete examples of what we're doing and how the technology is really delivering for us today.
That's awesome. So Donna, Bill, before we go to Q&A, I wanted to ask you for your advice or guidance you give to your counterparts in other health systems. I can make this quick, but Donna, starting with you, what's one piece of advice you'd give it to a health system that's actually looking to implement AI for surgical growth?
I guess be open-minded and not afraid of it, actually. The build, there is so much AI technology built out there that it's intuitive in building these systems. It is not hours and hours, as we would have thought in the past, of creating rules, creating all these guidelines to utilize a system like Qventus. So it's been just a benefit for both our clinic side and the hospital side. But being open to it is definitely where I would start.
Yeah. And what about you, Bill? What's one piece of advice you'd have?
Yeah, I'm building on Donna's comments. I would say that the technology is here. It's working. It's adding value now. In my mind, this really does need to be a core competency for all systems. I think if you do not embrace this technology now, you're quickly going to be left behind. So building in the structures, the cultural awareness, making sure that the teams are discussing it, that you build a framework to really support the use of technology in the administrative areas. I think it's the time is here, and it's really important to make sure you actually do it in a mindful way. So I think the timing is right. It's a really exciting time to be in healthcare. I think this technology is really a significant changer for us all. Yeah,
I would agree with that. I think it's not a business as usual. It's a really exciting time to be in healthcare and affect change. All right, I'm going to turn it over to the Becker's moderators. Thank you for some question and answer.
Thank you, Bill, Donna, and Dr. Tashby for a wonderful discussion today. We'll now begin today's Q&A. Audience, please feel free to submit your questions via the Q&A box on your screen. Let's go ahead and get started with the first question. For the first question, what is the perioperative coordination solution doing to help your nursing staff?
I can take a stab at that. Donna, feel free to add in if you like. So I think for us, it's really trying to eliminate the friction that the nursing team is encountering on a daily basis. So in this case, we've got great people who are doing great work, but this is really intended to eliminate those friction points that get in the way of what they're trying to accomplish. We could not actually contact every single patient for pre-anesthesia screening consistently. And so with that, this technology really is enabling their performance improvement, letting them do what they really love to do, and then also ensuring that we're not causing unnecessarily delays that could be otherwise avoided in surgical interventions. So trying to really just make that whole area as efficient as possible. And then with that, also identifying where there may be something in an H&P that could have gotten overlooked. So also trying to improve the safety of the team. So that would be my quick answer.
Yeah, and I think that the anesthesia screening tool has allowed the nurses to focus on the patients that require it. So that gleaning of those high risk, complex patients and letting them be attentive to those patients and truly removing from the healthy individuals having very routine procedures, what might be an annoyance of extra phone calls, extra documentation, all of those things. Patients start to expect this kind of AI technology in preparing for surgery. So it's been a win-win where simple for patients with minimal life disruptions, and nursing being able to really target those patients who are complex and need all the additional time, resources, investigations. So it's been good.
Moving on to the next question, how much of the provider preference and practice pattern logic was created automatically through AI versus what required manual entry validation to ensure accuracy?
I think I alluded that in my closing comments, where I expected an overwhelming amount of data submission to create these kind of nuances. It took, of course, all of our historical data out of Epic. So the system already compiled scheduling patterns, usage patterns, all of those things for our providers, what procedures they were commonly doing, their top procedures listed. They're not in the OR on Wednesday. Don't ever nudge them on that. So, and then compiling the same average procedure length time that we have in Epic is in Qventus in offering the procedure times and booking availability. So it was seamless. It was really that data mining that happened on the back end. We did not build that manually.
Next question, does it overlay on top of Epic or access Epic data separately?
Yeah, I'll answer that one. It accesses Epic data directly. So we are directly embedded inside of Epic for the pull part. So we pull both historical data and real-time data out of Epic across the spectrum, inpatient, ambulatory, surgery. But then we also write data back into Epic. So everywhere that there are endpoints that we can write back into Epic, we do that. So for instance, the inpatient space where we do ancillary prioritization, that actually happens in Epic. The Qventus algorithms are in real time dynamically reprioritizing the work queue that the labs and RADs and PTOT teams are using to decide who to round on next. That's fully embedded in Epic. You wouldn't even see Qventus there.
Time for just one final question here. For measuring results, how did you align on the data? Is there built-in reporting that Qventus has, or did your team have to put that together? How do you attribute ROI directly to Qventus?
David, do you want to start with that one?
Yeah, I'll give a quick blurb, but I think it'd be great to hear your perspective. I think Qventus from the get-go has taken a really conservative approach. I think to be fair to a hospital, we have to draw a direct line at the individual part level. At least each way that we marketed it, each case we were able to get into that time. And then I'm sure we offer a lot of soft benefit as well. And there's probably a lot more that we do specifically to drive the door, but we don't necessarily take credit for that. And so we create a aligned methodology on what a successful incremental case looks like, and then we track it in real time. And there are dashboards for this team, both to see what engagement has been in real time with each part of the platform and where there's opportunities for improvement and where there's opportunity for kudos, because there's been a huge win, and then what the outcomes have been at the individual level for each solution overall with the ROI.
Yeah, and I can build on that. So yes, the system, the Qventus system and platform does give us a lot of deep data and analytics. And in addition, obviously within the system, we still have our own data and metrics as well. So that combination, I think, gives us a really deep insight into how we're actually performing and what we're able to track.
That's all the time we have for today. I want to thank Bill, Donna, and Dr. Attachru for an excellent presentation, as well as Qventus for sponsoring today's webinar. Thank you for joining us today, and hope you have a wonderful rest of your day.
Thank you.